Hi, everyone, and thank you for joining me. My name is Rose Cortha Lorfels, and I'm a licensed insurance agent specializing in Medicare planning with Sunrise Benefit Advisors. Since becoming a licensed insurance professional in 2011, I've helped individuals and families understand their coverage options with a strong focus on Medicare over the past 10 years. Today's session is strictly educational, and my goal is to help you clearly understand how Medicare works so you can make informed decisions. I know Medicare can feel overwhelming at first, so my goal today is to break it down in a way that feels simple, clear, and practical. Before we begin, take a second to think about how familiar you are with Medicare right now. You may be brand new, you may understand the basics, or you may have already done some research but still have questions. No matter where you're starting, this presentation is designed to help. We likely have a mix of experience here, and that's perfectly okay. I'll keep things simple while also adding the deeper information people need to make real decisions. So let's go ahead and get started. So why does understanding Medicare matter so much? Because the choices you make when you first enroll can affect your health care, your costs, and sometimes your options later on. And one thing many people don't realize is that some Medicare decisions are easier to make the first time than they are to change later. That's why learning the basics now can save you stress, confusion, and money down the road. Today, I'm going to walk you through a few key things. We'll start with what Medicare is and how it works. Then we'll go over the different parts A, B, C, and D. We'll talk about the main coverage paths people choose when and how enrollment works, and some of the most common mistakes to avoid. By the end of this presentation, you should have a much clearer understanding of how Medicare works and what to look out for when it's time to make a decision. Before we continue, here's a Medicare planning worksheet for you. This worksheet is designed to help you think through what matters most to you as we go through today's session. You can download it now and follow along, or you can fill it out later after the presentation. Some people like to take notes as they listen, and others prefer to listen first and come back to it afterward. Either way works perfectly. The purpose of this worksheet is simply to help you organize your thoughts so that when you're ready, you have a clearer idea of what kind of coverage may fit your needs. Alright, now that we've set the stage, let's get into the teaching portion and start with the foundation of Medicare. Medicare is the federal health insurance program for people age 65 and older, and for some younger individuals who have certain disabilities or serious health conditions. Medicare eligibility is not based on income, although income can affect what some people pay, and some people with lower income may qualify for additional help. Medicare coverage can be received either directly from the federal government or through a private health plan. When someone receives their medical coverage directly from the federal government on a fee-for-service basis, that is called Original Medicare. Original Medicare is made up of two main parts, Part A and Part B. Part A is often called hospital insurance, but it covers more than just a hospital room. Part A generally covers inpatient hospital care, skilled nursing and rehabilitation care for a limited period after a qualifying hospital stay, blood hospice care, some home health care tied to a hospital or skilled nursing stay, and inpatient psychiatric care up to Medicare's lifetime limits. So when you think of Part A, think inpatient and facility-based care. Part B is medical insurance. It covers a wide range of outpatient and professional services, including doctor visits, outpatient hospital care, lab work, imaging like MRIs and CT scans, durable medical equipment. Home health care not covered under Part A, physical and occupational therapy, ambulatory surgery center services, and outpatient chemotherapy. It also covers many other items and services like ambulance transportation in certain situations, some preventive services, diabetic supplies, dialysis, outpatient mental health care, and CPAP devices. So the simple way to remember it is Part A is the inpatient side and Part B is the outpatient and medical side. Now let's talk about who qualifies. To be eligible for Medicare Part A and Part B, a person generally must be age 65 or older, or under 65 with certain disabilities or health conditions, specifically people who have received Social Security or certain railroad retirement disability benefits for 24 months, as well as people with ALS and people with end-stage renal disease are eligible. Medicare also requires the person to be a U.S. resident and either a U.S. citizen or a lawfully admitted permanent resident who has lived in the United States continuously for 5 years before applying. One of the most important teaching points in this section is that Original Medicare is only Part A and Part B. Under Original Medicare, you can receive covered services from any physician or facility in the United States that accepts Medicare, and no referrals are required. That flexibility is one reason many people like Original Medicare, but the trade-off is that Original Medicare also has deductibles and cost sharing, and that cost sharing can add up if someone uses a lot of care. So let's look at the math for 2026. For most people, Part A is premium free if they or a spouse worked and paid Medicare taxes long enough. If someone does not qualify for premium-free Part A, the 2026 monthly premium is $565 for people with fewer than 30 quarters of Medicare-covered work, or $311 for people with 30 to 39 quarters. For Part B, the 2026 standard monthly premium is $290 and the annual deductible is $283. Some people pay more for Part B based on income. And after the Part B deductible is met, people in Original Medicare usually pay 20% of the Medicare approved amount for covered Part B services. Here's a simple example. Let's say you have a Part B covered outpatient service with a Medicare approved amount of $1,000 and you have already met your Part B deductible for the year. Under Original Medicare, you would usually pay 20%, which would be $200, and Medicare would pay the other 80%, or $800. That 20% has no built-in cap under Original Medicare by itself, which is one reason many people later look at Medigap or Medicare Advantage as a way to manage out-of-pocket costs. Part A has its own cost-sharing structure too. In 2026, the Part A inpatient hospital deductible is $1,936 per benefit period. After that deductible, covered inpatient hospital days 1 through 60 have no daily coinsurance. Days 61 through 90 cost $434 per day, and lifetime reserve days cost $868 per day. Skilled nursing facility coinsurance for days 21 through 100 is $217 per day in 2026. So yes, Original Medicare gives broad access, but it does not mean all care is free. Enrollment timing matters too. Some people are automatically enrolled in Parts A and B, especially if they are already receiving Social Security or Railroad retirement benefits. Others have to sign up. The initial enrollment period begins 3 months before the month someone turns 65, includes the birthday month, and continues for 3 months after. If someone misses their first chance to enroll in Part B and does not have a valid special enrollment period, they may have to wait for the general enrollment period, and there can be a late enrollment penalty. Now, about the enrollment penalty, the Part B premium increases by 10% for each full 12-month period that someone could have enrolled in Part B but did not. This penalty generally does not apply if the individual delayed enrollment due to having qualifying group health coverage based on current employment. In that case, they can enroll during the special enrollment period that follows. The good news is that Medicare also has help available for people with limited income and resources. Some beneficiaries may qualify for help through Medicare savings programs, Medicaid, and the Part D low-income subsidy, also called Extra Help. You can reach out to Social Security and your state Medicaid offices to get assistance. I can be of help as well. So for someone listening to this who feels worried about cost, the important message is this: do not assume you have to figure it out alone. Original Medicare also comes with beneficiary protections. People in Original Medicare have the right to appeal coverage and payment decisions. They can also file grievances or complaints about provider behavior or quality of care, and they can get help through Medicare's 24-hour helpline and through their local state health insurance assistance program, or SHIP. It's important to note that Original Medicare does not automatically include outpatient prescription drug coverage. Beneficiaries who choose Original Medicare may obtain Part D prescription drug coverage through a standalone prescription drug plan. Most beneficiaries need to actively select this drug plan themselves. Therefore, if someone opts for Original Medicare for medical coverage and also wants prescription drug coverage, they typically pair Original Medicare with a standalone Part D plan. Here's the key takeaway. Original Medicare is the federal government's fee-for-service version of Medicare. It consists of Part A, which covers inpatient and facility-based care, and Part B, which covers outpatient and medical care. This option provides broad access to healthcare providers throughout the country, as long as the provider accepts Medicare, and it does not require referrals. However, Original Medicare does have deductibles, coinsurance, and other out-of-pocket costs that beneficiaries need to manage. This is why our next conversation is crucial. Once people understand how Original Medicare works, the next question is, how do you protect yourself from the coverage gaps? That's where Medigap comes into play. Now that we have a clear understanding of Original Medicare, let's discuss Medigap and how it helps cover the gaps that Original Medicare leaves behind. Now that we've covered how Original Medicare works, let's talk about one of the most important ways people try to protect themselves from out-of-pocket costs, and that is Medigap, also called Medicare Supplement Insurance. Medigap is not the same thing as Medicare Advantage, and it is not a replacement for Original Medicare. Medigap works only with Original Medicare. In fact, it is illegal to sell a Medigap plan to someone who is already enrolled in a Medicare Advantage health plan. So right from the start, the big picture is this. If someone chooses the Original Medicare path, one option they may look at is adding a Medigap policy to help with the gaps Original Medicare leaves behind. What exactly are the gaps in Original Medicare? Previously, we mentioned that Original Medicare provides excellent access and flexibility. Beneficiaries can receive covered services from any physician or facility in the United States that accepts Medicare, and no referrals are required. However, Original Medicare also has significant deductibles and other cost-sharing requirements. For instance, once the Part B deductible is met, beneficiaries typically pay 20% of the Medicare approved amount for Part B covered services. This means that Original Medicare does not impose a cap on the 20% share, unlike Medicare Advantage plans, which have a maximum out-of-pocket limit. That is where Medigap comes in. Medigap is sold by private insurance companies to help fill some or all of those gaps in Original Medicare coverage, such as deductibles, coinsurance, and certain co-payments. Some Medigap policies may cover limited benefits not covered by Part A or Part B, such as extra days of inpatient hospital coverage or foreign travel emergency care. Medigap generally does not cover long-term care, routine vision or dental services, hearing aids, eyeglasses, or private duty nursing. So Medigap is not an all-purpose extra benefits plan. Its main purpose is to help with cost sharing tied to Original Medicare. One of the easiest ways to understand Medigap is through a simple math example. Let's say you have a Part B covered outpatient service with a Medicare approved amount of $5,000. Under Original Medicare, once your deductible is satisfied, Medicare would generally pay 80%, which would be $4,000, and you would generally be responsible for the remaining 20%, which would be $1,000. That remaining share is exactly the type of expense people are talking about when they say Medigap helps cover the gaps. Depending on the Medigap plan a person selects, the supplement may pay some or all of that remaining cost sharing. All Medigap plans pay for some or all of a core set of costs. These include Part A coinsurance, up to 365 additional hospital days after Medicare's hospital coverage ends, Part B coinsurance or co-payments, the first 3 pints of blood, and hospice coinsurance or co-payments. Let's discuss the Medigap letter plans, as this is often a source of confusion. Medigap policies are provided in standardized benefit plans identified by letters from A to N. This means that in most states, the core medical benefits associated with a specific letter plan are consistent, even though premiums, pricing, and customer service may differ between insurers. It's important to note that Massachusetts, Minnesota, and Wisconsin have their own standardization systems, so the conversation about letter plans is most applicable to states using the A through N classification system. Additionally, states determine which standardized plans can be offered, so the availability of these plans may vary by location. There is also an important rule for people who became eligible for Medicare on or after January 1st, 2020. Those individuals may not purchase a Medigap plan that pays the Part B deductible, which generally includes Plan C and F, including high deductible F where applicable. Timing is a crucial factor when it comes to Medigap. When you turn 65 and enroll in Part B, it triggers a 6-month Medigap open enrollment period. During this time, Medigap insurers are required to offer you a policy regardless of any pre-existing conditions. This is known as a guaranteed issue, right? It's important to understand that Medigap does not include prescription drug coverage. If someone has original Medicare along with a Medigap plan and wants drug coverage, they typically need to enroll in a standalone Part D prescription drug plan. Individuals who are enrolled in Medigap can only access Medicare drug coverage through a standalone plan. Therefore, it's helpful to think of Medigap as a three-layer system. Original Medicare covers Parts A and B, Medigap helps with some of the cost sharing, and a separate Part D plan is necessary if the person wants outpatient prescription drug coverage. So who tends to like the Medigap path? Usually it is people who value flexibility and predictability. They may want the freedom to use providers nationwide who accept Medicare, and they may want help reducing the financial exposure that comes with deductibles and coinsurance under original Medicare alone. So here's the big takeaway. Medigap works only with original Medicare. It is designed to help fill some of the gaps left by original Medicare, especially deductibles, coinsurance, and other cost-sharing amounts. Medigap plans are generally standardized by letter, and the timing of enrollment matters because the 6-month open enrollment window tied to Part B is one of the strongest protection points a beneficiary has. Now that we understand how Medigap works with original Medicare, the next question is, what if someone wants a private plan alternative instead? That brings us to Medicare Advantage, also known as Part C. Now let's talk about Medicare Advantage, also known as Part C. Medicare Advantage is another way people can choose to receive their Medicare benefits. Instead of getting their medical coverage directly from the federal government through original Medicare, beneficiaries in Part C enroll in a private health plan that contracts with Medicare to provide their Medicare-covered benefits. These plans must cover all Part A and Part B benefits, and many also include Part D prescription drug coverage. Many plans also offer extra benefits that original Medicare does not cover. One of the easiest ways to understand Medicare Advantage is to think of it as an all-in-one private plan option for Medicare. Original Medicare is the federal fee-for-service path. Medicare Advantage is the private plan path. Both are still Medicare, but they work differently. All Medicare Advantage plans must cover Part A and Part B benefits. All of them have a maximum out-of-pocket limit for basic benefits, and many also offer supplemental benefits. So when people compare original Medicare to Medicare Advantage, they are usually comparing not whether they have Medicare, but how they want to receive that Medicare coverage. There are several types of Medicare Advantage plans. The most common are HMOs and PPOs. HMOs generally use a provider network, and enrollees may be required to choose a primary care provider and get referrals for specialty care. HMOs do cover emergencies outside the network, and there are certain other exceptions like out-of-area dialysis or urgent services when the network is not available. Some HMOs also offer a point of service option, which allows some out-of-network care, but usually at a higher cost and with more limits. PPOs are more flexible. Under a PPO, enrollees may get care from any provider in the U.S. who accepts Medicare and the plan, but they usually pay more when they go out of network. PPOs generally do not require a referral to see an out-of-network provider. They usually pay more when they go out of network. PPOs generally do not require a referral to see an out-of-network provider. Special Needs Plans, or SNPs, are Medicare Advantage coordinated care plans specifically designed for certain groups of beneficiaries. There are 3 main types of SNPs. 1. Chronic Special Needs Plans, CSNPs. These plans are intended for individuals with specific chronic conditions. 2. ISNPs, IESNPs. These plans are for people who need an institutional level of care, which includes those residing in nursing facilities or individuals in the community who require that level of support. 3. Dual Special Needs Plan DSNPs. These plans serve individuals who are eligible for both Medicare and Medicaid. It's important to note that SNPs are not available to everyone. Individuals must meet specific eligibility criteria for the type of SNP they wish to enroll in. Additionally, all SNPs include prescription drug coverage. Other Medicare Advantage plan types include private fee-for-service plans called PFFS plans and medical savings account plans called MSAs. A PFFS plan allows members to receive covered services from any provider in the U.S. who is eligible to provide Medicare services and agrees to accept the plan's payment terms. But that flexibility comes with an important warning. Not every provider has to accept the PFFS plan. MSAs are another unique type. A Medicare MSA combines a high-deductible Medicare Advantage plan with a special savings account that Medicare helps fund. If the member uses up the account funds, they continue paying out of pocket until they reach the deductible, and then the plan pays 100% for covered services. MSAs do not include Part D drug coverage. Now let's talk about who can enroll in a Medicare Advantage plan. To be eligible, a beneficiary must be entitled to Part A and enrolled in Part B. They must permanently live in the plan service area, and they must be a U.S. citizen or lawfully present. Medicare Advantage plans must generally enroll any eligible beneficiary who applies, regardless of health status, although special needs plans only enroll people within their targeted populations. When comparing costs, Medicare Advantage can differ significantly from original Medicare. Medicare Advantage plans may have a premium, which means beneficiaries usually have to continue paying the Part B premium in addition to any premiums for their specific plan. One of the key financial protections offered by Medicare Advantage is the maximum out-of-pocket limit. All Medicare Advantage plans are required to have a maximum out-of-pocket limit for Part A and Part B benefits. Once a member reaches this limit in cost sharing, the plan will cover 100% of the covered medical services for the remainder of the year. For 2026, the maximum out-of-pocket limit for coordinated care plans and PFFS plans is set at $9,250, although many plans may establish a lower limit. Additionally, PPOs must have an aggregate limit of $13,900. Here's a simple way to picture that. Let's say someone is enrolled in a Medicare Advantage plan with a $5,000 maximum out-of-pocket limit, and during the year they have repeated hospital stays, outpatient treatment, specialist visits, and imaging. Their total covered medical bills may be far higher than that. But once the member's own cost sharing reaches that $5,000 limit, the plan pays 100% of covered Part A and Part B services for the rest of the year. That limit feature is one of the biggest differences between MA and original Medicare. People often consider Medicare Advantage plans due to the additional benefits they provide. Unlike original Medicare, Medicare Advantage plans may include supplemental services such as vision care, hearing aids, and routine dental care. Starting in 2026, Medicare Advantage plans will also be required to send members a mid-year notice regarding any supplemental benefits they have not yet used. For members with certain chronic conditions, some plans may offer additional targeted benefits such as transportation, groceries, or other supportive services. Medicare Advantage plans may use utilization management tools, which means they may require referrals or prior authorizations for certain services. These plans may also implement step therapy rules for specific medications. If a person enrolls in a plan after beginning a course of treatment, there is a minimum 90-day transition period during which the plan cannot disrupt or require reauthorization for that ongoing treatment. Now let's talk about prescription drugs. Many Medicare Advantage plans include Part D drug coverage, and those are called MAPD plans. If a beneficiary enrolls in a plan that includes Part D coverage, they can only get their Part D benefits through that plan. If they enroll in an HMO or PPO plan that does not include Part D, they generally cannot add a standalone plan. Finally, Medicare Advantage enrollees also have protections. They have the right to file grievances, get coverage decisions, and appeal certain plan decisions about payment, services, or prescription drugs. Medicare Advantage is the private plan path under Medicare. These plans must cover all Part A and Part B benefits, often include drug coverage, and include an important financial safety net through the MOOP limit. Now that we understand Medicare Advantage, the next step is to look closely at prescription drug coverage, because Part D has its own rules, costs, and decisions. Now let's talk about Medicare Part D, which is Medicare's prescription drug coverage. Part D covers certain prescription drugs, biologics, insulin, some supplies used to inject insulin, and vaccines that are not covered under Part B. One of the biggest things to understand right away is that Part D is only provided through private companies. There is no fee-for-service Part D benefit directly from the federal government. Part D benefits come through standalone prescription drug plans called PDPs, through Medicare Advantage plans that include drug coverage called MAPDs, through certain cost plans, and through PACE plans. To be eligible for Part D, a person must be entitled to Part A and or enrolled in Part B and must be a U.S. citizen or lawfully present in the United States on or before the enrollment effective date. But how a person gets Part D also depends on how they receive their Medicare medical coverage. In general, people in original Medicare can enroll in a standalone PDP. People enrolled in an MA, HMO, or PPO usually must get their Part D coverage through that Medicare Advantage plan instead. And people in an MSA may only get Part D through a standalone PDP. Let's talk about what Part D covers and what it does not. Part D includes many common outpatient prescription medications, but it does not cover every possible drug. Specifically excluded are certain medications for weight loss or gain, fertility drugs, cosmetic drugs, many vitamins, non-prescription medications, and drugs that are already covered under Part A or Part B. This is why it's important to check a plan's formulary. A formulary is a list of drugs that the plan covers. While plans may not include every medication in each category, they must meet certain requirements. These include covering at least 2 drugs in every therapeutic category, offering both generic and brand name options, and covering all or nearly all drugs in 6 protected classes that treat life-changing or life-sustaining conditions. Plans also organize their covered drugs into cost-sharing tiers. For example, lower tiers often include generic drugs and cost less, while higher tiers may include non-preferred brand drugs or specialty drugs and cost more. So when someone is choosing a Part D plan, it is not enough to ask, is my drug covered? A better question is my drug covered? What tier is it on? And what pharmacy gives me the best cost? Now let's get into the 2026 math because this part matters. Under the standard Part D benefit for 2026, the beneficiary pays a deductible of up to $615. After that, during the initial coverage phase, the beneficiary generally pays 25% of prescription drug costs. Once the beneficiary's true out-of-pocket costs, also called TROOP, reach $2,100, the person moves into catastrophic coverage. At that point, the beneficiary pays nothing for covered Part D drugs for the rest of the year. That is one of the biggest changes people need to understand in modern Part D. The coverage gap has been eliminated and the out-of-pocket exposure is capped. Here's a straightforward way to understand it. First, there is the deductible phase, during which the beneficiary must pay 100% of costs until the deductible is met. Next is the initial coverage phase, where the beneficiary typically pays 25% of the cost. Once the beneficiary's out-of-pocket expenses that count toward total out-of-pocket reach $2,100, catastrophic coverage begins, and the beneficiary pays nothing for covered Part D medications for the remainder of the calendar year. Additionally, there are 2 special protections. Covered insulin cannot cost more than $35 for a 1-month supply in any coverage phase, and recommended adult vaccines covered by Part D have no cost sharing. It is also important to understand what counts toward TROOP and what does not. In general, the deductible and cost sharing for formulary drugs purchased at network pharmacies count toward TROOP. But costs for non-formulary drugs that are not approved through an exception, over-the-counter drugs, many out-of-network purchases, and drugs bought outside the United States do not count. So when someone says, I spent money at the pharmacy, that does not automatically mean all of that spending moves them closer to the catastrophic phase. Choosing a pharmacy is also important. Part D coverage is typically provided through a network of pharmacies. Some plans designate specific pharmacies as preferred pharmacies, which offer lower cost sharing compared to standard network pharmacies. In certain limited situations, a person may use an out-of-network pharmacy, like when traveling, but this may come with higher costs. Therefore, when selecting a Part D plan, it is crucial to consider not only the medications covered, but also the pharmacy network, and to verify whether their usual pharmacy is a preferred one. Part D plans may have a monthly premium. Generally, a higher premium may result in lower out-of-pocket costs within the plan. It's important to be aware of the late enrollment penalty. If a person does not enroll in Part D when first eligible and goes without coverage for at least 63 continuous days, they may have to pay a penalty set at 1% of the national average beneficiary premium for each month, and usually lasts for as long as they have Medicare prescription drug coverage. However, individuals who qualify for the low-income subsidy, also known as extra help, are not subject to the late enrollment penalty. Employer or union drug coverage can protect individuals from penalties if that coverage is considered creditable. Each year, employers and unions are required to inform their members whether their drug coverage qualifies as creditable. If it is creditable and an individual later loses this coverage, they can typically enroll in a Part D plan within 63 days without facing a penalty. Therefore, check your options before dropping existing plans. Part D plans also use management tools. These can include prior authorization, step therapy, quantity limits, and generic substitution rules, but beneficiaries do have rights. They can request a coverage determination, ask for a formulary exception if a drug is not covered, request a tiering exception if they need a lower cost tier, and appeal if the plan says no. Plans must also provide transition refills in certain situations, such as when someone is newly enrolling, switching plans, or affected by a formulary change, so people are not suddenly cut off. One more important feature is the Medicare prescription payment plan. Part D sponsors must offer enrollees the option to spread their costs across monthly payments instead of paying at the pharmacy counter. This option does not change what counts toward TROOP or how the benefit phases work, but it can help smooth out cash flow, especially for people who have high drug costs earlier in the year. For individuals with limited income and resources, assistance may be available. Beneficiaries should be encouraged to apply for the low-income subsidy, also known as extra help, through Medicaid or Social Security. Some individuals qualify automatically, including those with full Medicaid coverage, recipients of certain Medicare savings programs, and people receiving Supplemental Security Income, SSI. The module also includes examples of cost sharing for the low-income subsidy in 2026, demonstrating that eligible beneficiaries may have a zero deductible and very low copayments. So here's the big takeaway. Part D is Medicare's prescription drug coverage, but it works through private plans, not directly through original Medicare. Choosing a plan means looking at more than just the premium. And most of all, you want to avoid missing your enrollment window because going without creditable drug coverage can create a penalty later. We now understand how Part D works. The final step is putting everything together so people can compare original Medicare, Medigap, Medicare Advantage, and drug coverage in a way that fits their real-life needs. Now that we've covered the main parts of Medicare, let's connect this information back to your planning worksheet, so you can start thinking about which path may be the best fit for you. As you look at your worksheet, think about what matters most in your real life, whether that's keeping your doctors, managing prescription costs, having more predictable out-of-pocket expenses, getting extra benefits, or having the flexibility to see providers nationwide. This is the point where Medicare stops being just information and starts becoming a personal decision, because the right path depends not only on how the plans work, but on how you actually use your health care. Before we wrap up, I want to take a few minutes to go over some of the most common Medicare mistakes people make. This part is important because even when someone understands the basics, small mistakes can still lead to penalties, higher costs, or coverage that doesn't fit their needs. Mistake 1, missing enrollment deadlines. One of the biggest Medicare mistakes is missing enrollment deadlines. That can lead to delayed coverage and, in some cases, long-term penalties. For example, if someone delays enrolling in Medicare Part B and does not qualify for a special enrollment period, they may have to pay an extra 10% for each full 12-month period they could have had Part B but did not enroll. And in most cases, that penalty stays with them as long as they have Part B. Part D has a penalty too if someone goes 63 days or more without drug coverage. Mistake 2, not reviewing coverage annually. Another common mistake is not reviewing coverage each year. Plans can change their premiums, provider networks, pharmacy networks, formularies, and cost sharing from one year to the next. Even if you were happy with your plan last year, it's still a smart idea to review it again and make sure it still fits your doctors and budget. Mistake 3, choosing based only on price. A lot of people focus only on the monthly premium. But the premium is only one part of the picture. A lower premium does not always mean lower overall cost. A plan may look affordable, but if it has higher copays or deductibles, it could end up costing more over the course of the year. Mistake 4, not checking doctors or prescriptions. This is another big mistake to avoid. With many Medicare Advantage plans, provider networks matter. With Part D, costs depend on whether your medication is on the formulary. So before enrolling, it's important to make sure the plan works with the doctors, medications, and pharmacies you actually use. If any of those sound familiar, you are definitely not alone. These are very common situations and they happen to people every year. The good news is that once you understand how Medicare works, these are all things you can avoid. Now you should have a much clearer understanding. And this is exactly where that Medicare planning worksheet comes in. It helps you think through what matters most based on what we covered today. Now, it's completely normal if you still have questions. If you'd like help reviewing your options, I'd be happy to connect with you one-on-one. I can walk through your choices based on your doctors and personal needs. You can reach out to me directly when you're ready. No pressure. Thank you so much for spending this time with me today. I hope this helped make Medicare feel clearer, simpler, and a lot less overwhelming.